essentially no side effects. New vertebral fractures, you can see reduction 60, 70%. Here's the reduction in non-vertebral fracture. Here's the reduction in hip fracture. There weren't a lot of fractures in this trial, but they were same benefit. Here's the change in BMD. Got up to about an 8% increase at 3 years. Similar results for reclass. Again, not quite as effective as Forteo in terms of change in bone mineral density, but similar fracture protection. What happens if you randomize patients to a Prolia or alendronate? Alendronate wins. I mean, alendronate loses, the Prolia wins. It's a better drug than oral alendronate in terms of change in BMD. So its indications are identical to that of Forteo. High risk for fracture. This is not approved for osteopenia, only for osteoporosis. And unfortunately, it's not approved for men. So no men can get this one unless you take steroids or have something else going on. So it's only been studied in women. The same risks again, which is hypocalcemia, must have your adequate vitamin D. There is listed in here a risk of skin and infection. We've not seen any of this, but it's in the package insert. You must know about it. ONJ in the clinical trial, they had one in the study group and one in the placebo group. So it wasn't zero, but people without these drugs get osteonecrosis as well. And a few patients can have musculoskeletal pain, and maybe one patient had pancreatitis. So if we can summarize all this, our job as practitioners is to persuade you that this is a benefit to take one of these therapies, that it will reduce your fracture risk, that if we know the side effects, we can monitor those and make sure that you follow appropriately. If you do not respond to oral therapy, we need to change therapy. We need to go on to something else. And when should we change? How often should we change? Which one do we continue for how long? And we make sure we worry about the issues of the side effects. So I think I'm going to stop showing slides and let you ask any questions, because I think it's easier if we go about it that way. Yes, sir.
Strange question. With the placebo group, did you actually take that placebo group later on and start the same treatment to see if they behaved as the trial group did?
It depends on which agent you're choosing, but yes, those trials have been done.
Okay.
So if you take the Prolia trial, they had a placebo group for 3 years, and at the end of 3 years they put them into the active therapy, and they respond as well.
Okay, because we did that.
Right. So yes, it demonstrated that if you stopped it, started it, stopped it again, each time you started it, whichever group you got a response. Okay.
Yeah. I'm sort of interested in the whole reclass thing because I had the salespeople come in and they talked to me about how easy it would be to order this treatment. And it is pretty easy to do. And I'm struck by the fact that it's a once-a-year treatment and that you don't have to worry about this whole absorption issue. It goes in and it's there and you're done. And yet, it's been very difficult for me to not to get anybody to use it, but when I bring up that as a possibility, it usually gets dismissed very quickly. Now, I'm an internal medicine doctor, you're an endocrinologist, so maybe your experience is different, but can you comment on that? Maybe also with respect to other internists that,
About why patients are unlikely to want to use this therapy?
Yeah.
Sure. One of the common questions I get is, if I'm allergic to it, will my allergy last the whole year? Because now the drug is in my body and it's never leaving. And the answer to that question is, it's in your bloodstream for a few hours and that's all. And then it goes into your bone lining, and it's not actually in the bloodstream anymore. So you can't be allergic to it beyond the first day or so. So you don't see a persistent side effect that lasts beyond that first 24 to 48 hours of that flu-like syndrome. We explain it to the patient that this avoids the GI side effects. There are no GI side effects because you're not swallowing it, you're not going to have heartburn. And so the side effect profile is really clean. The ONJ risk is very low. And the other thing we haven't mentioned was this atypical femoral fracture question, which is also not described so far for patients who take reclass. So if you present them with the adequate information and they think of the alternatives of having to swallow a pill weekly or monthly, or have already failed that, and then switch to reclass, I think you get much greater effect. And then if you explain how easy it is to get it done, that it's only a half-an-hour procedure from beginning to end, I think we probably get 70% acceptance when we suggest this as a choice. Yes.
Dr. Green, I get reclass, and I get it in your office, and I don't have any problem.
There we go.
Good, very good, I'm glad.
Yes.
I've been on a reclass, I think it's about my 3rd year, and I was wondering, why do I still need to take so much calcium when I take that?
Okay, now there's a good question. If I can repeat that, is what's the role of the calcium supplementation when you're taking some other therapy, in this case reclass? I explain it this way. If you take reclass and no calcium, it's like buying a gun and no bullets. If you don't have something to load into the bone, you really can't accomplish very much. So you need, the question is so much calcium. You need to have adequate calcium intake, because when you make bone, what you do is first you take these osteoclasts, they come in there and they eat up the surface of the bone. Then osteoblasts come along and lay down a protein matrix, which is flexible, but it has to be mineralized to become solid and reduce your risk of fracture. That's where the calcium comes in, and the vitamin D. Without the calcium and the vitamin D, you'd have soft bone.
But then now they suggest me taking magnesium with it as well.
There's very little data about adding magnesium or vitamin K or all these things that people want to throw into supplements in terms of benefiting your bone. What we know about clearly is calcium and vitamin D. None of these clinical trials ever added magnesium as a supplement on either arm, placebo or the active arm. So we have very little data about magnesium. I wouldn't worry about the magnesium part.
Okay.
Yes.
I have severe itching on my arms and legs from sometimes psoriasis. And I take I think they call it a corticosteroid cream. In fact, I take 2 kinds of this. I've been taking it for some time. Is there any relationship between deterioration of the bone mass because of taking these topical steroids for a long period of time?
Very good question. And the answer is, if you cover enough skin with enough steroid, you can have suppression of your bone turnover and affect your osteoporosis. So it is possible. Depends how much you put on, how much skin you cover, and Dr. Green can actually measure your adrenal function and see whether or not it's being suppressed by the stuff that you put on. If it is, then you're at risk for further bone loss. And you should be treated as if you're taking oral steroids. Yes.
Now, granted, your mother-in-law was 93, but if she had a hip replacement earlier, or anybody, would this stuff help people who have hip replacements make that hip stronger?
Oh, I didn't show you that information. I'll come back. I'll cover that though. She actually broke the other hip 10 years before that. So this was the second hip that she broke. And she actually broke the first hip twice. And so, and she was treated for osteoporosis in between, but my mother-in-law is not the world's most compliant patient. I can't say more than that, but she's not. We actually had her on Forteo for a while, but I'm not sure she ever took it on any kind of regular basis because I wasn't there to watch. The question of these drugs and healing fractures is a real question, okay? So there's a little bit of data that says that Forteo may accelerate healing of fractures. And so it would certainly not be harmful. Let's say you fell down, not you, but someone fell down, broke their hip. When should you start the therapy? Well, the orthopedists have this idea that bisphosphonates, Fosamax, Actin, Alboniva, block healing. There's no data for that. They're wrong. Because in all these clinical trials, people break bones. I mean, I didn't do 100% protection of anything. And all these people heal. So non-healing fractures on bisphosphonates simply is not increased. But Forteo may actually accelerate the healing. So there's no reason not to start it, even if you've had a fracture. And Forteo may actually improve that. Does that answer your question? Or is there another part of your question?
I've just had so many hip replacements, and they just wear out.
It has nothing to do with healing of your hip replacement. It will not benefit it, and it will not harm it.
Okay.
So, you know, you're talking about a hip replacement. You have to get the screws to set into the bone and have the pins sit in there, whatever it's supposed to be doing. In general, what orthopedists do is if you're on a bisphosphonate, they want you to not be on it while this is going on. But there's no data for this. This is simply their mode of practice. It's not with clinical information. Yes?
My mother was on a Forteo, that's the injection, is that the one that you get every day for
Yes.
2 years?
Yes.
And they said that it only helped her 5% of helping with the bones.
Okay, so there's an improvement of 5% in the bone density. Okay, so 5% is not bad. It's not as good as 10%, but it's not bad. Was she on something before